Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and joining me today is my medical director, Rob Dixon.
Good afternoon, Casey.
This is a special episode, one that we probably should have gotten to before now, that was a bit of your aha moment, and I can't take credit for it, but really it's the reason behind the podcast, sort of in opposite form. Tell the listeners about what we're going to be talking about today.
Right. This is podcast Q&A. So we started, or Casey and the clinical team, it was really their baby, started the cast to have a wide audience. And really it was started for our paramedics here at MCHD, or focused on our paramedics, but it's kind of really had a lot of spread around to different agencies and different types of providers. And one of the things that we really wanted to focus on was that we were giving what the medics wanted and have that open line of conversation with the cast between the audience and us. And so in that spirit, we're going to take some of the great ideas that our listeners have sent us and some of their comments and just talk about those, talk about some cool clinical stuff today.
In putting this together, this was, the Q&A episode was your idea, and it does go back to the original point of the podcast, and that was to try and reach our 300 MCHD medics on their own turf. It's hard to get everybody into the same lecture hall and to do a old school classic PowerPoint presentation. Right. We do quarterly CE, but even then it's difficult to have ongoing conversations. And so my goal from an educational side was to open the line of communication. So when I saw medics on shift in the ED, hey, this is a syncope patient, doc. I listened to the syncope episode. What do you think about this? And when medics do that to me on shift, that's like, big old heart time. That's when I'm like, yes, it's working. But honestly, some of these emails that we've gotten
are fantastic,
are awesome.
Yeah.
And we just took 2022. So I took the last 6 months or so and went back to the podcast email and took all of the emails that we had received and looked through and collated them, and that's what we're going to go through. So we'll go back to February, mid-February. Sam Jeffress, a local medic. He's an Aggie. We're supposed to do Aggie
Should
things.
I do a whoop right now, doctor? I don't know. I'm not an Aggie.
I'm from Kentucky, so I don't know. But Sam's question was a great one, and it was actually one that we had discussed in the office. He asked, can we talk about Penthrox or methoxyflurane? And I thought, man, that's a good one. We were interested in Penthrox or methoxyflurane, the green whistle. It's been used in Australia for decades with excellent pain relief and analgesic properties. It's an anesthetic gas when used at higher doses. And at higher doses, back in the 50s, 60s, there were some episodes of hepatic failure here in the States. And so it was FDA X'd. And there is movement towards limited FDA approval for study here in the States again, but it's really sort of sad when you combine the fact that we're dealing with the opiate epidemic that we don't have access to this medicine here in the United States, that we can't use it single dose, patient administered, non-opiate, great for trauma, really good trauma data out of Europe, Canada, and Australia. I would love to have the green whistle here at MCHD. We've actually had some preliminary discussions with the manufacturer, but right now the limitations on use are so strict that it probably wouldn't be a good choice.
The juice wouldn't be worth the squeeze on that one, Casey.
We use it 6 times a year.
Way cheaper and way easier to use, and I think would be used a lot more by our medics for those patients like a fall you got to extricate with a fracture or something. The Nitronox we have, it's expensive. You got to put it together, and I think that limits its use here.
Sure. So it would be used similarly,
very similar
to nitrous oxide. So that was Sam's question. Sam should have gotten a T-shirt in the mail from us for his great question and for his engagement. So thanks, Sam. Keep the questions coming. In mid-March, we got an email from Jeffrey Siegler, Dr. Jeffrey Siegler. He's an EMS doc at WashU in St. Louis, and he listened to the Airway Patency Protection podcast. And we struggle with some of the S's, and he said, "Hey, I've got you. It's sonorous, stridor, smashed, singed, and soiled." So he came up with soiled for the vomit, the blood-filled airway. And man, when somebody comes up with that idea that just hits you in the face, obvious, I at first was jealous. I'm like, why did I think of soiled? And then I realized that he sewed the lecture shut. From here on out, I've got it down. So
thank you, Dr. Siegel. Yeah. We're going to give that one to the residents soon, so we appreciate that.
We got also March was a hot month. We got another one in March from our very own Olivia Kaufman here at MCHD, and
she is our former, but now we got her back. Welcome back, Olivia.
Yeah, Olivia. Hers was really feedback on the airway protection versus patency lecture.
Right.
And she described the case where she had cared for a patient and was questioning whether or not to proceed with advanced airway management. The patient was very hemodynamically unstable. She expressed, and it made me feel great, I was much more confident to use foundational BLS techniques, bag, resuscitate, and transport with hemodynamic stability as the goal, rather than diving into medication-assisted airway management too quickly and ending up with a peri-intubation arrest, peri-intubation hypoxia, hypotension. So she took more of a comment route as opposed to a question, and just said, hey, it really helped me in a recent case, helped me be more confident, and there's nothing more that we want to hear than you're taking this information, taking it to the patient, to the street, to the bedside, applying it, and feeling better about your daily patient care. I was like, man, that's a great email. Thank you, Olivia.
That's why this exists.
Yeah. Right. In April, we got a couple in April. Jason Irely emailed us. Jason didn't put his location in the email. Sorry, so we don't know where you're from exactly. But Jason requested some pain management specifics. Honestly, we've talked a lot on the podcast about different pain medication options. We've talked about nebulized ketamine. We've talked about nitrous oxide. We've talked about, way back when, hydromorphone. We've had some fentanyl discussions. But honestly, Jason's questions and some issues that have come up here in the Department of Clinical Services has led us to put together a recent slide deck lecture presentation that we're going to use here with our In Charge Academy, which will translate into podcast episodes. Don't quote me on it, but I think we'll see a 3-part series looking at the progression of pain management. So not specifically pharmacology of individual medicines, but more how do you progress?
Right. We were just talking with our In Charge Academy downstairs about sedation, and I think Casey used a metaphor which is really pretty accurate. Right. When you have a mouse, you don't need a double-barrel 12-gauge shotgun to dispatch said mouse into the hereafter. Right.
Mousetrap.
You need like a mousetrap or a BB gun or something for people that shoot mice. So I think it does translate. Right. We have to consider the whole spectrum of pharmacologic and non-pharmacologic options we have, which I think is a couple of podcasts, which is really, really good stuff. I've done that more in my practice. I think that we can get in such a practice pattern that mine was like everybody gets morphine or everybody gets fentanyl. And mine now is a lot more tailored. And really it changed it when I worked abroad in New Zealand, is that they take that multimodal approach to it. I used a lot more PO, pain medications in the emergency department before I escalated to an IV or IM form. So I think that's a great topic.
Yep. So we will be bridging off from your question, Jason, into hopefully a pain progression, the pain practical management as opposed to specific pharmacology here in the future. We got another one in late April from Jason Taylor. Jason works in Loudoun County Fire up in Northern Virginia, and he sent some really positive feedback about our whole blood episode 125, and sent some YouTube links for us from his service and some of the ways that they manage whole blood.
Which I thought we had not thought about before,
in the pre-hospital
Jason,
setting.
So thanks. It was really neat.
Yeah, so we'll link his YouTube, his service in the show notes. And video's worth 10,000 words. Check it out. They're doing some really awesome stuff there in Loudoun County. I was able to speak with their medical director. Super engaging folks, very helpful. Really appreciated the feedback, appreciated the contact. So thank you, Jason, for sharing. We got one from literally across the globe in May 13th. We got one from Maria Roundtree. And Maria is a nurse medic in Victoria, Australia, not Victoria, Texas. She sent kudos, said she was an avid listener. Just amazing, and wanted to mention because the reach that we've had definitely was never anticipated at the beginning.
No, we never expected that. We expected our 300 medics and our 1,000 plus first responders that, practice here in the county. I never thought it would be over 50 countries now represented or something like that. So it's great. We're super appreciative for the feedback and super appreciative of the listeners.
Yeah, and we've got people in fire services, we've got EMS docs, we've got MCHD in-charge medics, we've got a nurse medic from Victoria, Australia at this point. So thank you for the feedback. Yeah. We appreciate the kind words, Maria. And she mentioned riding out here at MCHD. So Maria, if you're listening, you're welcome to come ride out anytime. We can make that happen for sure.
Absolutely. We had a group from the University of Melbourne that came every year, and they got shut down right during 2020. They were rostered to come in 2020. That got put on hold, and I expect that at some point we'll get that back. And we had probably 15 or so in that group from University of Melbourne doing their paramedic training courses that came down and did some field time with our crews. And I thought it was a great collegial exchange of information. It's a great program.
What happened in 2020? Did something big happen?
I think it was that COVID.
COVID
thing.
COVID.
It kind of got in the way for a couple of years.
That's
there.
my just terrible attempt at sarcasm. we got a cool one in early June. On June the 8th, we got an email from Bodie Nolan. Bodie's a primary care medic in British Columbia. And his question was, what are your thoughts on indirect pressure control for acute hemorrhage? And there's some, we didn't prepare a literature-based response to all these questions. We really just wanted to acknowledge the questions. So there's lots of ways that this question can veer off into junctional tourniquets and some other different tactical approaches to non-extremity hemorrhage. But one of the more interesting ones, in just poking around and replying to Bodie, which is often the fun part for me, is getting asked the questions that I don't really know the answer, so I'm going to have to go poke around and learn. I ran into a really interesting tactical paper on a term called Knee-BOA. So
Knee-BOA, like Reboa with a knee.
Knee BOA.
Enlighten me, doctor.
Well, if you've got lower extremity exsanguination or pelvic hemorrhage that you don't have access to a Reboa, you're in a tactical setting or you're in an austere setting, you use your knee and put your knee in the abdomen of the patient to compress the lower extremity bleeding. And there's actually been cases of this that have resulted in pretty decent hemorrhage control.
You heard it here first, listeners.
Knee-BOA. I will
well
put
done,
the
Bodie.
I will put the link.
Did you send that guy a T-shirt?
He got a
Send
T-shirt,
that guy a
and
T-shirt.
the cool part, we need to grab Misty. I'm not a social media person per se. I'm too old for that. But Bodie was a cool cat and sent me a British Columbia patch. So I've got a patch in the office.
Very cool.
So
Thank you.
Really cool. Yeah.
Very cool.
622 is another one, literally around the world. Etan Yammer from Israel sent us a question about IV acetaminophen data internationally. I would urge all the listeners, if you're interested in our IV acetaminophen work here at MCHD, listen to episode 117.
Yeah.
There is a ton of IV acetaminophen literature out there. Most of it is operating room based and hospital based. There is not a ton of IV Tylenol EMS. I want to soapbox just for a second. I've seen in the blogosphere Twitter sphere, FOAMed world, some push recently to almost disparage IV Tylenol. And I get it.
I think they're piling on. I didn't like this last paper that came out. I thought it was done really, I didn't when I read it, I was like, I'm not sure what they're trying to do here.
And let me sum up your concerns, because we've talked about it a lot. Number one, I get it if the cost is 10x medication B, that you probably want to use medication B instead of IV acetaminophen. We don't want to break our systems using an expensive medication that's equivalent or worse. So part of the reason we've really moved to use more IV Tylenol here at MCHD is it's generic now and it's cheaper. So the cost issue is not the gigantic hurdle that it used to be. Secondly, I see a lot of these papers looking for opiate equivalents or opiate minimization. So in other words, if we use IV Tylenol, we can minimize the amount of opiate that we use. Both of those are valid goals. But number one, I don't think anyone would expect IV Tylenol to be as good as hydromorphone. That just doesn't pass the common sense test to me. That's probably in the unrealistic
expectation box, and I would agree, Casey. I mean, this is an armamentarium, and this is going to be a good topic on just pain management, our approach to it, and the different pharmacologic and non-pharmacologic therapies out there for it. You have to tailor the therapy to the individual patient. Not every patient is appropriate to get fentanyl. I go lower and slower in some of them. Depends on the patient, depends on the level of distress, depends on the injury or illness.
And so I don't know that opiate reduction as a final endpoint is always the be-all, end-all when you're looking at pre-hospital pain relief. We have so much less information about the patient, i.e. their renal function. We don't know the renal function. We don't always have a complete medication list. So when you're taking care of elderly patients who may be borderline in their hemodynamics and we don't know where their renal function is, we don't know where their mental status is going to be, to have a medication like IV acetaminophen that we can give with no mental status effects or significant mental status effects and no effects on renal function, it may not be as good as hydromorphone, but it may not have the same side effect profile. And yes, if cost is in range, I think that's a great tool for our toolbox.
Yeah, we should have our peer-reviewed paper hopefully in publication by next year on this topic here, putting it against our patients that got ketorolac, which is, I think, a comparable substitute medication for that particular kind of middle-of-the-road pain patient is a fair comparison. I'm going to jump on my soapbox just one time, and then we can move on.
Sure.
Whenever you're ready. I can't wait for the pain podcast, because we are never going to hurt someone in EMS medicine, in emergency medicine. We are in the death and disability business, and our job is to sort out for those serial killers one dose of pain medication to get the patient, symptoms calmed down. While we're doing that and finding those deadly killers or ruling them out is not harming patients. Sending them home from the emergency department with 2 double handfuls of hydromorphone tablets does hurt them. So don't be afraid to use appropriate doses of narcotic analgesia, right? I think that this whole opiate sparing thing, I think it's the pendulum swinging on the whole narcotic problem, the opiate problem in this country. And I don't think it's good for our practice to be hyper-focused on, oh my gosh, I don't want to give that patient 25 of fentanyl. I may hurt them. We're not going to hurt someone with that.
That said, I will push back a little bit. I don't know that we argue on the podcast very much. We try to have a shoulder-to-shoulder approach here. But I would also say that not everybody needs a narcotic. And
I agree.
Some patients are more fragile and more medically fragile, and to have options that are adequate in pain relief, like if we had methoxyflurane, Penthrox, the green Rissel, that is a non-narcotic. If we have an IV acetaminophen that's cost reasonable and maybe safer from a mental status depression standpoint, hemodynamic depression standpoint, we still have to balance both those things. So Agreed. I don't know that we disagree there. I think that's just, there's 2 sides to that coin and probably more than 2 sides.
For sure.
Last one we want to hit on is just from last month in July. We're recording this in early August. So we got a question from Austin Brook. He's a flight nurse in flight nurse school in California. So we got somebody that's up in the air, out there helping, taking care of our sickest of sick patients. And he says, what do we start our epi drips at in anaphylaxis? Is it the same dose as our pressor dose? And really good question. I don't know that I'd ever thought about there being any difference between an epi drip dose in a pressor situation or an anaphylaxis situation. The reason why I say that, and I emailed you, Austin, but to answer the question for everyone else, is I see epinephrine as a vasopressor in both situations. I don't see it as a different dose because it's anaphylactic shock with the benefit of the beta effects and bronchodilation. But I'm not changing the dose. Our epinephrine dose, just for the listeners out there, is 2 mics start dose up to 10 mics of epinephrine. We've actually had discussions around the office about, we've had some patients that have gotten fluids, gotten access, gotten epidrips, gotten push dose epi, and still been hypotensive in the 80s to 90s. And should we have a higher ceiling on our epinephrine dose, on our norepinephrine dose? And honestly, my answer off the protocol record is that we probably should go to 20 mics for both norepinephrine and epinephrine.
I think most of our providers start at more than 2. The most common, when we talk about scenarios, they talk about their cases, they hit it right in the middle and start at 5 mics per minute.
And go to 10.
And then our IM dose, just for the listeners out there, you can listen to the anaphylaxis. We did a great cast, a really enjoyable one. Anaphylaxis is 0.3 IM. And
I would say for the MCHD listeners, making protocol changes is always a little bit more difficult than just saying it into action. We have to make sure that we edit the protocols. We have to make sure that there's no, wait, you didn't think about this. And we have to make sure that we change it in all the protocols that branch off from the med reference. So just expect sometime in the coming months to see potentially that ceiling raised from 2 to 10 up to 2 to 20. So we've got California flight medics, flight nurses. We got medics in Israel. We've got a primary care medic in British Columbia, fire service in Virginia, MCHD feedback via email, EMS doc, WashU, and a good old Aggie. It wouldn't be MCHD if we didn't have some Aggie input. The Aggies are around and they're powerful.
They're all over this place.
And I'm from Kentucky, so I'm neutral. But when we put this together, I thought this episode was going to be a dud. I didn't think it would be enough material for an episode. I thought it was a good idea, but I thought, man, there's not that many emails and the questions. I don't know. And I went back and collated it and was blown away. I think I probably called you or texted you way too late and was like, man, there's all these people from all these places that have listened and asked these really wonderful questions. And so this is our thank you to the listeners out there for sticking with us and for really making us do the fun work of digging into this stuff. And that's the fun part of the job. So thank you all for listening. Anything you want to add before we wrap up?
No, just our thanks. I think that it's been, and my thanks to you and the clinical team. I mean, this has been a labor of love for Dr. Patrick. He doesn't take nearly as much of the credit as he should for this. So I'm super proud of what you've done here with this, and the impact it makes in the medical community, I think, is enormous. So thank you.
Well, we'll probably have another podcast out of this one. Sam's Penthrox question. We've not had a Penthrox episode, so we probably should go methoxyflurane sometime in the fall, so I'll add that to the list. Y'all should have your T-shirts in the mail. Thank you for listening. Thank you for sending us questions. We really appreciate it. As always, if you have questions, send them to us, podcast@mchd-tx.org. Wherever you watch on YouTube or listen on Spotify or iTunes or wherever you listen to your podcast, please leave us a review. We like 5 stars because it hurts our ego if you give us less than that. If you think we can do something better, instead of giving us a 3-star review, send us some feedback and we'll try to fix it. As always, thank you for listening. We'll be back with another episode soon.